takes pleasure in attracting a stellar list of speakers that address today's most relevant issues. The club's place as a refuge for rich discussion and networking has never wavered after 123 seasons.
We are dedicated to encouraging debate on the issues that matter to this city, this province, and this country.
The Canadian Club is one of the most important podiums anywhere in the world that a Canadian can speak to, tell Canadians what it is that they think, develop those thoughts. And so I want to thank you for that very, very much.
Please join me in thanking our esteemed panelists today.
Through our programs and events, including our youth and young leaders programs, our diversity partnerships, our joint events, and our media and social media opportunities, we offer you access to dynamic political, social, and business figures from abroad and right here at home.
The platform from which the eloquence of Canada has flowed all of that time, whether it be business, education, politics, sports, arts, and culture. If someone wants to say something to Canadians about this country and about the future of this country, this is the venue you choose.
Hello, and thank you for joining us. My name is Anita McCuitt, and I'm president of the Canadian Club Toronto and national leader of TMT and consumer markets for PwC Canada. Well, we're all users of the healthcare system, but I don't think many of us spent much time thinking about it on a daily basis before last year. Fast forward 1 year since the WHO declared a worldwide pandemic, and Canada's healthcare industry continues to adapt to the unprecedented needs of battling COVID-19 and the resulting crisis. To thrive in a post-COVID world, how will healthcare companies take a more nuanced approach to achieving long-term sustainability, growth, and patient-centered care? Today, we're joined by Bain's Dr. Tim van Biesen to share his insights from his international work and to explore the vast implications of combating the coronavirus. But before we dive into today's topic, here's some information about how you can participate with us. The click here to switch stream button is available to you if you find your internet is slow, your video quality may decrease, but the audio should stay strong. And we do want your questions today. So if you have any, just click the questions tab, type your question into the window, and it will go straight to our moderator. We want to thank Innovative Medicines Canada for your generous sponsorship of today's event. We are a nonprofit at the Canadian Club. We've been bringing people together for 124 years, and we could not do it without the generous sponsorship of our sponsors. After some brief remarks, Tim will be joined in conversation by Jodi, Independent Corporate Director and a seasoned Canadian healthcare executive. So before we get started, one of the club's traditions that has not changed in this virtual world is a toast that we make to our country at the start of every event. So if you have a glass of water, coffee, or anything nearby, please join me in a toast to Canada. Now I'd like to turn the podium over to Pamela Freilich, President of Innovative Medicines Canada, to introduce Dr. Tim van Biesen and Jodi Butts.
Thank you so much, Anita, and welcome everyone. Bonjour à tous et à toutes. Today is a National Day of Observance for those who've lost their lives to COVID-19. And so on behalf of our IMC members, I do want to extend deep sympathies to those who have suffered such unimaginable loss, as well as heartfelt thanks to all essential workers who have put their lives on the line so we can be safe. Well, we have been working virtually for almost a year, as Anita has just said. It still feels somewhat awkward saying, I'm pleased to be here with you today from the comfort of my own home. Fortunately, there is some hope that we may one day soon be able to be together in person for an event like this, and thanks in large part to the efforts of, among others, our IMC members. Innovative companies like Pfizer, AstraZeneca, Gilead, Lilly, Janssen, Medicago, and others, they're all working around the clock to develop and deliver the treatments needed for those infected with COVID and the vaccines to stop its spread. Notwithstanding the many valuable products our companies provide and that all of us depend upon at one time or another, I have never been more proud of this industry and of the contribution it's making to protect Canadians. The collaboration that has taken place over the last year, it's across industry, governments, researchers, academia, patient groups, and it's fueled the discovery, development, approvals, and the delivery of therapeutics and vaccines in record time. Processes that would normally take a decade or more have been accelerated without risking the safety of Canadians, particularly our most vulnerable, through this challenging period. We have cut time, but not corners. We're working not only for all Canadians, all citizens of the world, but our own families as well. Safety and efficacy are paramount. As a result, barely a year after the virus took hold in Canada, we're already able to begin focusing on the country's social and economic recovery. That is remarkable. It also reinforces the value of the country's life sciences sector and the role of innovative medicines in the health and well-being of Canadians, which does lead us right into today's discussion. While the entire healthcare sector remains focused on the fight against COVID-19, there are indeed important lessons to be learned from the last year. Chief among these is the power of collaboration. If we truly want more patient-centric, innovative, resilient health systems, we need all stakeholders, particularly I would highlight the innovative medicine sector and government, to work together. By working together, we can build a life sciences ecosystem that will protect Canadian patients' access to the newest, most innovative medicines. It will attract investment to Canada, foster innovation, and contribute to more robust domestic manufacturing capacity. Simply put, the progress we all hope to see in the wake of COVID-19 cannot and will not happen unless industry is seated at the table. Beyond the obvious focus of IMC members on innovative medicines, we all know and we want to help address the many health systems challenges which have existed for years and the pandemic has brought into even starker relief. Is this our opportunity to get long-term care right, to advance the use of health teams in medical homes, keeping people in their homes as long as possible, expanding scopes of practice, evolving clinical guidelines, reorganizing human resources, consolidating health information, finally? There is a long list of opportunity. We have with us today two people who will share their unique takes on these issues and much more. I want to welcome Jodi Butts, a lawyer, corporate director, and health policy advisor, and Tim Van Biesen, as you heard, a fellow Canadian and a world healthcare practice lead and senior partner with Bain, who brings a truly global perspective to today's discussion. I'm confident I speak for everyone with us today when I say that the focus of your discussion could not be more timely. For that, and on behalf of Innovative Medicines Canada and our member companies, I want to thank the Canadian Club of Toronto for once again providing a vital platform for people to engage on one of the most important public policy issues of the day. I look forward to the discussion. And with that, welcome, Tim. The virtual floor is yours and Jodi's.
Thank you so much, Pamela. It's really my distinct honor to be here with my fellow Canadians today. I want to thank the Canadian Club Toronto, Innovative Medicines Canada, and my co-host Jodi Butts for having me as part of today's program. I'm looking forward to the discussion, and I'm looking forward to the questions from the group. It is indeed interesting timing that today is a National Day of Observance for the victims of COVID-19. Almost 25,000 dead in Canada, over 2.5 million globally, almost 1 million documented infections in Canada, almost 120 million globally. There is no precedent for this in our time, and it has rocked, of course, the global economy and most definitively the healthcare system to its core. To tackle this topic of trends in healthcare is a massive undertaking, and we'll do our best to focus on the issues that matter most today. This sector represents 15% plus of global GDP. It's not really just a sector. It's not really just an industry. This has to do with manufacturing, services, high science, retail and consumer products, financial services, technology, transportation, social science, education, and government policy. It touches on almost every aspect of life around us. There are a lot of challenges in global healthcare. They vary very much by geography, but they all coalesce around two common issues of funding and access. There are a lot of things to be excited about in healthcare. We spend a lot of time worrying about how to make it better, but I do want to ground us in what's gone well in healthcare over many decades. Some of us will remember that 40 years ago, there were no treatments for mental health disorders. 20 years ago, there were very few treatments, if any, for cancer and oncology. 15 years ago, there was nothing around rare diseases that today are receiving a great deal of attention. And just last year, we saw in what might go down as one of the most innovative windows of time in history, the very rapid global deployment of vaccines to a disease that we barely understood a year ago. Just a shocking timeline. Interestingly, all of these therapies, vaccines most visibly, and antibiotics with them, increase lifespan. What's interesting about that is that actually allows for an increased rate of other morbidities to creep up, some of which we've talked about, neurodegenerative diseases as an example. That was a non-issue in the 50s when the average global lifespan was only 46 years. It was 66 in developed countries, but that is an unheard of number now. We're well into the upper 70s and low 80s in developed countries. So we're faced with the task of delivering an ever-increasing volume of products and services to an ever-increasing number of people. This thing keeps growing, and it's hard to get your arms around it. So what's working, what's not? Well, here's what's working. Diagnoses are faster, they're more accurate. As I said earlier, there are more treatments for more diseases than ever. The standard of care is always improving. Access is by no means widespread or equitable, but it is improving systematically over time. Patients have more visibility and choice into the care that they receive than ever before. And technology and travel have begun to standardize and normalize the standard of care across geographies. There are plenty of things that aren't working. Equitable access is absent in almost every part of the world, including all developed countries. And that is an issue that requires constant vigilance and government action to resolve, and private sector action. We haven't fully aligned incentives between individual and population outcomes. We'll find different governments in different parts of the world solving for different things, all of them for good reason. But there is no such thing as a healthcare system that doesn't make some form of a trade-off. And it's a question of whether you trade off the collective good or the individual good. And some of that will come up in some further remarks. COVID is, as I said earlier, really complicated this situation. This is endemic. It is no longer pandemic. We've talked about it as a pandemic, but COVID is not going away. We are going to live with it for a very extended period of time, if not, frankly, in perpetuity. So it will become a part of everyday life. Baseline immunity, or some form of herd immunity, has already shown a massive decrease in the mortality rate, and infection rates are going to go down. So we will figure out how to adapt to this so-called new normal. Besides the obvious direct tragedy of this first introduction, in which the population had no immune response to it whatsoever to tolerate it, we saw all kinds of other negative effects. A massive restriction to access to care that led to increased mortality from non-COVID diseases. This is most visible, for example, in cardiovascular care. You see these sometimes referred to as excess deaths. So additional people who have lost their lives because they were not able to access the care that they would have done in the absence of the pandemic. Deferral of all kinds of other procedures and surgeries, some of them known as electives, but they're not that elective when you think of a knee or a hip replacement. A lot of those surgeries haven't been happening because of, again, a lack of access to care. And perhaps the most visible and perhaps the most enduring one is a rapid increase in the need to serve the mental health, the behavioral health community, which has grown, and changing the model by which that's done. one of the mechanisms that's born out of this, sometimes innovation is bred by these disasters, is an increased use of telemedicine. It's one of the main trends that we might touch on today. There was a massive, almost 1,000-fold increase in the use of telemedicine across different countries in the world. I'm intrigued by what happened in China, where they made the most rapid switch to telemedicine and have sustained a very high level of utilization. What we've seen in other developed markets is actually a rapid retreat to in-person care whenever that's possible. So it will be interesting to see where we see an equilibrium between those two, particularly insofar as telemedicine is used to substitute for what used to be in-person care or to complement in-person care and serve as a form of triage, for example. There are a number of other trends I want to touch on, and Jodi and I will discuss some of these as we go through the rest of the discussion. We will see a resumption of a previously stalled out focus on outcomes-based care, outcomes-based reimbursement. The trend towards that had slowed previously. When I say outcomes-based, for those of you who don't quite know what that means, it is rewarding the delivery of care on the basis of the result that it creates, rather than the activity that you put into it. So rather than, for example, in paying for the administration of drugs, procedures, and diagnostics, you actually pay for the cure or for the improved quality of life or the like. That is a very noble goal. It's one that we should continue to pursue. It is incredibly challenging and has been difficult to implement in many different regards. But we will see increased pressure to pursue that. We will see a new era of accelerated, rapid, and agile drug development. What we saw in the last year for vaccine development is absolutely mind-boggling. What took many, many years in the past and very extensive clinical studies was squeezed into an incredibly short timeline without really compromising the quality of the clinical trials, the quality of the regulatory review, and the post-marketing surveillance that takes place after these products come to market. It can change the way drugs come to market over time. We probably have to increase resilience and sustainability of supply chains. Those broke, although they broke more temporarily than was expected. We saw shortages, for example, in PPE and ventilators in the very early days, but supply chains broke down everywhere. We saw some food supply chain and other product supply chains break down as well. So manufacturers and service providers across the board are very focused on how to build additional security into their supply chains. I mentioned earlier a massive increase in the requirement for behavioral health and the mechanisms by which to deliver that. Another one is a shift to different sites of care. Many of us are accustomed to going to our local hospital, short-term acute care hospital, for emergency care or any kind of care. What we're seeing is an increased aversion to that, both by patients and physicians who would say, gee, I don't think I need to go to that massive institution. I can do this in an office-based lab. I can do this in an ambulatory surgery center, and it's more user-friendly, it's more physician-friendly, it can be more patient-friendly, and we're seeing volume move into some of those spaces. We're seeing cardiac procedures move into those spaces, cath labs, for example. We're seeing even one-day total knee replacements where you're discharged by the end of the day. Imagine that. That is how quickly that technology is changing. As is often the case in challenging markets, there's an increase in consolidation of healthcare companies. This would include providers like hospitals and physician groups, which we see very commonly in markets, more commonly outside of Canada, and certainly manufacturers and service providers. And we'll see some virtualization of the model. It's interesting. Healthcare, from my point of view, which I live and breathe every day, is probably the last, I should say, sector to truly undergo a digital transformation. It's very counterintuitive, given it's an innovation-driven business. But there's an argument to be made that healthcare is behind agriculture now. There are more smart farms than there are smart hospitals out there. It is a big hill to climb, but the investment is there, and hopefully we're turning that corner very soon. You know, a silver lining in this otherwise tragic pandemic is this, and we talk about this extensively with clients and policymakers around the world, a re-recognition that healthcare is a core part of a country's economic infrastructure. In fact, it's not much different than defense or roads and highways. And building a resilient healthcare system, when you wind the clock back a year, wasn't top of mind to people. Suddenly people find out that this is what undergirds so much economic activity and allows economic activity to continue. Good Lord, who knew we would be looking at walking into stores and restaurants with temperature monitoring and the like? No one would ever have imagined such a thing, but it is fully integrated. This means it can yield to coordinated centralized action. That can be at a national level, a global level, a industry collaboration level, but a little bit of the moonshot-like mentality that we saw over the course of the last year to develop the vaccines. And I say that because despite in the US as a great example, but other countries in the world as well, despite a very challenging political environment over the last 4 or 5 years, the Operation Warp Speed-like effort, it worked. It did deliver a whole host of different vaccines in an incredibly short period of time. It will go down in history as a resounding success, and we're already seeing tens of thousands of saved lives as a result of this. It's interesting, we also spend a lot of time working with financial investors in the space, private equity and others. This has become, it was already a very active sector in private equity and corporate M&A activity. It is now at its highest level ever. It accounts for 24% of the deal volume in 2020, which is the highest level it's ever achieved. Valuations for assets trading in this space are at the very top of the range. We have a massive increase in activity in other parts of the world, particularly in Asia Pacific. And it is, I think, for all the reasons I've just articulated, the central integral role of healthcare in everything that the economy does. So it has been a very challenging year. There's no doubt about it, but there is good reason to be optimistic. We may be nearing the end of the most difficult period of this as the vaccine deploys, as we see some form of herd immunity evolving, as we now have widespread testing. We begin to see signs, cautious signs, hopefully, not too hurried, of returning to some kind of normal economic and social and interpersonal activity. So I'll pause here and turn it over to Jodi. Jodi, you're on mute, I think.
Got it. Thank you very much for those enriching comments. Really appreciate it. Obviously, a lot to chew on there. And I think one of the, in a time filled with so much tragedy, one of the silver linings is that it's really demonstrated that we all share some of the same challenges. The U.S. has a very different approach to the health system than Canada does, but in many respects, we were fighting some of the same battles, nevertheless, even if they didn't have the same sources. We have lots of questions coming in, so I will jump in where I can, but we really want to hear from you, Tim. And the first question that we received was talking about have we learned from history when it comes to pandemics? Every pandemic seems to have followed a similar arc around denial and those who are hardest hit by them. Have you seen any bright spots in terms of how we've learned from past pandemics, and how might we carry some of these learnings forward? Maybe just get better at learning from our mistakes.
Boy, that's a loaded question, Jodi. I think the way I would answer it, we've learned a lot on the technology and science side, or we would not have been able to respond as quickly as we have. I think there have been people in the community, in the healthcare community, who predicted this. Most visibly, I think it would be the Gates Foundation has been predicting this for some time. And as such, not especially surprised. I think infectious disease specialists and virologists will tell you this was inevitable. And to some extent, the industry was a little bit primed to respond as quickly as it did. Thank goodness for the timing, because 5 years ago, the mRNA vaccines that are developed today weren't even technologically feasible. So there is some advantage in the fact that this happened at a time when those technologies have been further developed. Socially, No, Jodi, I don't think we learn much. I think we tend to repeat history. We confuse what is a purely natural phenomenon with social and interpersonal and political behaviors. We've seen almost inexplicable politicization of mask wearing and social distancing and business opening around the world. It is borderline irrational behavior, but it is what it is. If we have another pandemic in 5 years, we might have some memory. If it's 25 years, forget it. We will repeat it all again.
I think that's unfortunately probably true. I do think maybe the economic response in Canada and now the United States with the passing of its package, I think that is a bright spot. I think we've learned a lot about our economy and who are vulnerable, and hopefully we'll continue to see action on that front. One of the questions relates to insulin. So thinking about, the discovery of insulin and, some of the lessons learned there, as Canadians, we read stories about people choosing between, rent and food and insulin. And for sure, there are challenges here in Canada as well. Do you think we'll see some movement on that? Does the pandemic change maybe how we think about access to medicines?
Well, we can only hope that it does. And here I can only speak for myself. In my view, I think there must be a hybrid answer. It is interesting to contrast Canada and the United States, for example. Canada solves for the good of the whole. The United States, in everything it does, solves for the good of the individual. And healthcare should not be an all or none thing. There are basic healthcare supplies, products, and services that should be universally accessible. Maternity care, emergency care, vaccines and antibiotics, and products like insulin. And others may be very high-end, who knows what, cancer care and surgical procedures that cannot feasibly and economically be made available to everybody on an unrestricted basis. And we've got to learn, I think, to live in both those worlds at the same time. The point is a fair one. We live in a world today where somehow the concept of the cost of vaccine is not part of the narrative. Thank goodness it's not. We are not talking about that. We're not talking about out-of-pocket spending to get a diagnostic test or a vaccine. And you would like to think that there are disease states where more of that can happen.
Yeah, indeed. And, this also, you mentioned sort of the costs of vaccine. So that's not a barrier. But I think we're all a little bit worried about vaccine hesitancy, that as a barrier. The United States, obviously, way more advanced in their vaccine rollout than Canada. Prior to this pandemic, I think we would have said that our relative anti-vax populations were similar, but we're not necessarily hearing about wastage of vaccine due to people not showing up to get it. What do you think this is just a problem that's a little bit further down the road, like we haven't hit that hurdle, or do we think that maybe something's different here, that people are thinking differently about accessing vaccines?
Yeah, it's a couple of interesting observations I'll share, and then I'll answer your question. First, countries that did a differentially good job of managing the spread of infection, of which Canada is clearly one, and the United States is not, are the countries that are least prepared to deal with the vaccine for whatever counterintuitive reason. Maybe that's by necessity, because those countries that had very high infection rates, like I said, had no choice but to go hard after the vaccines. What's interesting, well, we've begun to see those, and here's a little bit of data. First dose vaccine administration is highest in Israel of scale countries, a little over 50%, which is high. Britain is at 32. The U.S. is coming up on 20. It's not too bad, particularly given the large population. Canada is a little bit below 5. China is at 4, and Australia is at 0.3%. They have almost no infection rate there. It is interesting to see how those two dimensions correlate. What we've begun to see, because there's plenty of vaccine hesitancy in the United States as well, but as the momentum is picked up, it started to wane. What you find is communities see, all my friends are getting it and they seem fine. People are getting on board quickly. So there's now hope that spreads, that as the momentum picks and local communities and countries see that increasing, and of course then economic activity resumes and you're able to go out and do more, people will get on board. It is this vaccine, for what it's worth, these vaccines, I should say in aggregate, are shockingly effective and safe. The flu vaccine is in a good year, 55-60% effective. I mean, it's a bit of a 50-50 shot as to whether or not you're truly protected. These things are 90-ish. It's quite amazing. They're almost 100 in terms of preventing deaths and hospitalization. Very, very close to 100%. There's very little precedent for vaccine efficacy at this level. And other than, the side effects are you feel miserable apparently after your second dose, is what they say.
I look forward to experiencing that.
Yeah, me too. But that's the worst of it. So that's a pretty good situation to be in.
Absolutely, absolutely. I think that brings up another question that we received from the audience, which is, what is the right approach to thinking about the pharmaceutical industry? It's just such a live topic here in Canada. And some of it is partisan, but some of it is, fact-based, historical-based, head-scratching, if you will.
Yep.
Do you have any advice? What's your perspective? Like, what's the best way to approach this sector? How do you engage with it effectively? And how do you nurture it?
Well, you must nurture it. I mean, look at how centrally important it was to working through this issue. So it's a sector that is of absolute necessity, of course, in every respect. But sometimes it hasn't done itself a lot of favors. Let's talk about a couple of things. First of all, it's the highest margin, most profitable business in all of healthcare. It is what it is. That's not in and of itself a sin. It just is. It just happens to be true for pharmaceutical products. It drives about 15% of total healthcare costs when you include everything now. Pharmaceutical, surgeries, medical products, every kind of care you can think of. So 15 is not a huge number. If you say as a rough approximation that its margins are 30-some%, then if you eliminated all pharmaceutical profits tomorrow, magically, you'd take about 3 or 4% of the cost out of the healthcare system. And it's not that, suddenly you're like, oh, okay, that's not going to move the needle enough. We're going to take 30% out. So there's a balancing act. Pharmaceutical companies have this unusual situation. They have no customer interface. In fact, in many countries, they are legally precluded from knowing who the end users are. So they work through this physician interface, but they can't know that I, Tim Van Biesen, came to get drug X. So they're this step removed from it. They spend a great deal of resources on research and discovery, research and development. Thank goodness that they do. They spend as much on sales and marketing. So now you're asking yourself the question, gee, is that the right way for us to allocate that? And that remains a fair question. What we've seen though is a technological ability over recent years. About 10 years ago, pharmaceutical industry was in a pretty substantial slowdown. They were running out of big disease areas to go after. We'd addressed hypertension. We'd done a lot of depression on gastrointestinal diseases and the like. And there's been a very good resurgence. There've been a lot of new products coming for a lot of underserved populations, some breakthroughs in oncology, a lot of rare diseases. And having seen the industry step up the way it has in the last year has been, frankly, you have to be inspired by what you've seen if you set aside for the moment some of the policy implications. So what I think we look forward to, and I had a conversation, as I mentioned to you, Jodi, a week ago with the person who ran Operation Warp Speed in the U.S. And an important takeaway he shared is, have we changed the paradigm of how we develop drugs? Can we do it faster, cheaper, sooner? Can we be more responsive? Can we be more patient-centric? And to me, that's it. If that's an outcome of this development for the pharma industry, we don't benefit from it.
Yeah, very fair. I think the black hats and white hats aspect sometimes of the discussion is what holds us back from achieving better. And for sure, there's lots of opportunity for better in Canada, and I think there globally we can do better in terms of identifying new medicines and achieving access to them, because there's no point in just developing them for the sake, right?
Absolutely right. Yep.
I
should mention, Jodi, if I could, because this access point, I'm glad you raised it in this context. There is a global program, a vaccine sharing program called COVAX, because many poor countries, they lack the infrastructure and the institutional ability to get vaccines out to the population. They don't have cold chain infrastructure and the like. This is a coalition that now has pulled together roughly $10 billion of funding. The G7 has been a major contributor. All African countries are enrolled. It relies quite heavily on the AstraZeneca Oxford vaccine because it's thermostable and it could get out to these remote communities. And the idea is that every country that purchases vaccines for its own population makes an allocation to COVAX. And so that you are simultaneously driving volume into countries that have no access or no resources to acquire. So it's interesting that also formed over the course of the last year so quickly, and hopefully works very well.
Yeah, obviously, I made some jokes, but I'm totally serious. Like I just very eagerly await, receiving a vaccine. But sometimes it is challenging to think about the national approach to it. I think COVAX is a good solution, but there again, I think there's probably some opportunities for improvement as well, particularly when vaccines that are more easily deployable across the world are, come online. We would be remiss if we didn't talk about racism in healthcare. In many ways, people have described it as the pandemic within the pandemic. Have we made some progress in terms of thinking about racism in healthcare, but also racism as a public health issue? Do you see any lasting changes coming from this moment and some of this new thinking?
I like the contextualization of racism as a public health issue. It is very much that, and there are organizations out there that have addressed it along those lines. We haven't solved this by any stretch of the imagination. It's not simply providing access and opening the door and say, you may come and have a vaccine or a COVID test. It's education, it's socialization, it's an economic issue. There was and I'm not going to have the date exactly right. The Rockefeller Institute did a study probably close to 20 years ago that went into underserved counties in the United States to offer full medical coverage. And the idea was to try and bring underserved population, particularly people of color, into the healthcare system. And what they found was, despite giving everybody coverage, thinking that was the magic solution, almost nobody turned up. And the reasons were very interesting, because the reality is some of these people were working 2 jobs, maybe in single parent families, and they would go to a physician the first time very quickly, bring their children, take them out of school, and guess what they heard from them? The kids are doing great, pat on the back, etc. And they said, well, I'm never going back. I had to take 4 hours off work. That cost me too much money. I had to drive 40 miles. It cost me gas. And they don't come back. So it is, in Canada, that's a very different mindset. We're raised with it. We were taught to go to the doctor. We never had any restrictions whatsoever. We didn't feel as though we were making trade-offs. But shifting people into that mindset, it takes a lot of work. So to say access is equal is not enough. To economically make it equal is not enough. We've got to create enablers to bring people into the healthcare system beyond what they've been taught to do to date.
Yeah, I mean, a huge challenge here in Canada too, for, some of the reasons you're getting at, cost and time are not the only barriers. Here in Canada, some really horrible instances brought to light during the pandemic of racism against Indigenous people in the healthcare system, including just a heartbreaking viral video. There is some work consultations have been initiated, and, looking at things, everything from legislation potentially to changing the demographics of who delivers care. And then the only other thing I would say is that, sometimes in Canada we forget, like, the healthcare system has a whole bunch parts of it outside of the single payer system. So, things like dental care, for example, there are some programs that support free dental care, but they're a bit of a patchwork, and just not knowing whether it's covered or not can also be a barrier to accessing what can be essential care for sure.
Now, the good news is my understanding is that Canada's Indigenous community is ahead of the rest of the country on its vaccination rate.
It is. It is, and it absolutely should be that way. So I want to talk a little bit about the role of strategies. We heard Biden talk about a cancer strategy. There was the moonshot, and you mentioned it in your remarks. But I want to delve a little bit deeper into it, because I think sometimes when we hear strategy, it sounds like a document that collects dust, requires a lot of effort from a lot of people. So lots of consultations, people show up. But then, what happens? In your experience, what are the positive benefits of there being disease-based strategies?
There are two things that come to mind. First is you create more of an open platform for data and technology sharing. That says, let's not try and figure this out 5 times over in isolation. Let's put the greatest minds together and share, particularly data, increasingly important, but also technology and competencies to see if that accelerates the path to a solution. That's one strategy that might bear some fruit. The second is it allows you to put in place proper incentives. Often for the private sector, which is totally appropriate, to engage in this in a very productive way. That takes a lot of thought. It doesn't always come out perfect. Someone will always try and game the system, but again, I think in many respects that can be better than trying to do these things in silos, which is the default approach.
Yeah, and I think you're right. I mean, Operation Warp Speed is a great example of the kind of collaborations that can result from the organization that comes from a strategy.
What we saw very recently, 2 weeks ago, Johnson & Johnson, as you know, came out with a vaccine, which is very exciting, and just didn't have the capacity to deliver at the levels that they aspired to. And the administration walked in and said, great, we'll put you together with one of the world's largest vaccine manufacturers, Merck, and use that capacity. And that's completely unheard of, frankly. You don't see that in the private sector until somebody connects the dots across the two. So. Absolutely.
So one of the things we saw was during the Trump presidency was the exit from the UN and the WHO. Biden is obviously going in a different direction on that, but will we see more global collaboration around diseases? Is that something that we can, cross our fingers, and also building on COVAX?
The scientific community will collaborate globally, irrespective of what political representatives tell them to do. It is instinctive to a scientist to think across borders. So I don't worry too much on that. These things, these things I think are transient in terms of what policy are. It is inevitable that global collaboration is part of the solution here.
Talking a little bit about health systems, so you've talked about a few comparisons there around different approaches around prioritizing individual access versus a more population-based approach. Let's put the lens of resilience up against these systems. What contributes to a health system's resilience? I think for the first time, in Canada, we talk about beds or, these types of things. Are we building new hospitals? But then all eyes turn to Lombardy, Italy. And we realized, well, maybe it's not even just about the number of beds, but something more complex called resiliency.
Yeah, well, that if we could solve that one, Jodi, we'd be very busy. But so it's a very good question. It's a very difficult trade-off. The reason we talk about beds is because at the end of the day, the hospital is treated as an economic factory, which is to say run utilization. And the colloquial phrase that's used, I kid you not, is heads in beds. That is the economic driver of a hospital's financial outcomes. But that's no way to think about healthcare. That actually, again, it's just that's a factory floor model, not a health outcomes model. So I think that raises
or a hotel.
It's exactly the same mindset. So we've got to figure out how to get how to put rewards in place that actually measure health outcomes. There have been multiple attempts to do so. It's exceedingly difficult to do that without somebody trying to take advantage of the situation. That's human nature. There's always somebody trying to take advantage of the situation. But that's been very difficult. There is no right answer to the question, because the trade-off that exists today, and out here I do like to contrast Canada and the U.S., is solving for the whole instead of solving for the individual. And again, which one do you prefer? Well, I prefer solving for the whole, but to be very frank, until I'm individually exposed to that risk or a member of my family is. And then suddenly your mindset shifts. And that's a very difficult dynamic, because healthcare, this is a very strange sector, is the only industrial sector in the economy, in the world, that has infinite price sensitivity. That is, there is no limit to what people will pay to save a loved one. They'll sell their houses, they'll give everything away, they'll go completely bankrupt. You would not do that in any other part of the economy. And you can't let the system take advantage of that. But that is, in fact, what happens, of course, and we read about it all the time. So it's an incredibly delicate balance to try to strike.
Yeah, I think that's for sure true. You know, I spoke with a philosopher, Mark Kingwell, and we were talking about health. He was like, well, you know, I guess in this pandemic has showed that, you know, health isn't a public good. You know, look at the way, you know, hospitals are operating. And, you know, my response to him was health, and especially population health, is without question a public good. And I don't know how you couldn't look at this pandemic and think that. But it's for sure true that once you get to that bedside, it looks more and more transactional.
Yeah, that's right. Because we pay for inputs, we don't pay for outputs. And and almost every system works that way. And yeah, we've got to figure out how to navigate that.
Which I think, you know, speaks to the, in part at least, a data challenge. And so I wanted to ask you, now I promised I wouldn't ask you to make predictions, but I think I've come pretty darn close to asking you to make predictions, and I'm gonna come up to the line again. But thinking about big tech, I mean, you can't talk about anything without talking about big tech. During the pandemic, we saw the sort of joint venture between Amazon and Berkshire Hathaway and JP Morgan just quietly closed down. But, you know, Google, Apple, and Amazon and other areas seems like they're still paying attention to healthcare. Do you think we'll see big moves from these companies? What should we be looking out for when we think about big tech and health?
But you mentioned predictions, Jodi, as you and I talked about before this session. The one thing that's been true about the predictions in COVID is that all of them have been wrong. So count on that. I can add to that repertoire if you want. You know, what you referred to, the Amazon model, was a business called Haven Healthcare. It was an interesting idea and brought together a financial expert in JP Morgan, a distribution expert in Amazon. And the idea was to take a large employee population together. They had about 1.5 million employees, and see if they could redefine healthcare. And it was frankly a little bit overambitious on one dimension. You can't end-to-end reinvent healthcare overnight. And the second is 1.5 million people is an irrelevantly small number. Shockingly, it sounds like a lot when you read it in a newspaper article, but in the grand scheme of things and in a data set, it is an almost meaninglessly small number, particularly if they all have a similar background. Bankers, forget it. They're all the same. So you're not going to get a representative cross-section of the population. And that's part of what may have made that especially complicated. Google, Apple, Microsoft, as you said, Facebook, have all made very aggressive plays in healthcare. None of them have taken yet. There's no question they will find a way. Again, it's in the US, it's 18% of GDP. In most countries, it's north of 10. And given the footprint that these companies have in these markets, they will find a way. In recent year or so, we've seen Amazon take a more tangible approach. It's building a retail pharmacy competency, for example, and hoping to deploy that. Working on durable medical equipment and medical supplies, and you can find many of these things online now. But there is a data play here, almost certainly. The data issue is a very complicated one, because the data that tends to be available is insurance claims data, be that in a single payer market or a private sector market. And insurance claims data is actually not especially useful. It doesn't include your blood pressure. It doesn't include your blood glucose level. It includes what claim was made and how much was paid for it. And it's also 90 days late. So you need clinical data. So then you say, okay, to the hospitals, I need that clinical data. And then they, maybe not so fast. I don't want my referral network to leak. I would like that to be an integrated system between my primary care providers and my specialists and my diagnostic centers. So again, you have all these fascinating incentives that prevent people from what everyone agrees is the right thing, but at a local level winds up being a very complicated hurdle. It will happen, Jodi. This is, as I said in my opening remarks, the digital transformation of healthcare is shockingly slow, but it has to come. It's just inevitable. The pressure, of course, will overwhelm, and at some point we'll see some meaningful forward movement.
So, of course, we also have to talk about long-term care. I think, once again, this is a dismal legacy that the United States and Canada shares in terms of the overrepresentation of older people in the death rates from COVID-19. But that hasn't been the experience of every country. So that would suggest there's some opportunities here for our countries to do a better job around how we care for older Canadians. What do you think might happen, and what are things that maybe for sure should happen?
As you point out, in Canada, I think over 60% of the deaths are in long-term care facilities, which I think is among the highest rates. Yes. And that may frankly say something about how well it was contained outside of long-term care facilities. Those ratios have, of course, two drivers to it. But it was a disaster inside long-term care facilities, which is very true in the U.S. as well. And New York is still trying to figure out what numbers it's going to actually lay claim to. The issue is a very serious one. Now, these two countries are very high users of long-term care. We, as a society in Canada and North America, have a tendency to put our seniors into long-term care facilities at rates much, much higher than in Europe, certainly Southern Europe, and elsewhere. So that balance was interesting. Let's take Northern Italy as an example. Seniors were differentially affected by COVID, but so were the very large part of the population. In Europe and in Northern Italy in particular, you have very common multi-generational living, 3 generations, all in one home. So if some person gets it, everybody's going to get it, or the large portion of that household will get it. I don't know any 3 generational families at all in North America. I'm sure they're there, but I frankly don't know them. It's so uncommon that it's the exception. So we have massive different social structures. We have massive different utilizations of space. They tend to live in apartment blocks, in smaller units. And so you get very different outcomes as we've seen. Your question about long-term care is a real one. What I'd like to see happen is a reduced dependence on long-term care. We've got to move people into home care. We've got to figure out how to deliver the therapeutic needs that they have, the nursing needs that they have in the home. It's safer. That's always been true, even before the pandemic. It's cheaper, which is by a meaningful long shot, and it's better, of course, for the individuals involved. So hopefully that is the trend. It's too early to know what happens to the overall population, particularly in skilled nursing facilities, which were the most directly affected. There are other long-term care facilities like inpatient rehab, long-term acute care, and others that have a different clinical need, but skilled nursing is the one we've got to sort out.
So just as we wrap up, and thank you so much to the audience for your excellent questions. These are all coming from you, so thank you for that. I'll just give you a nice wrap-up question, which is, what is the one thing you're most excited about over the next short term in terms of a development in healthcare? It can be an innovation, it can be a new sector getting involved, anything.
To me, it's the digital transformation. It's the big unlock in so many parts of what we do today. So if we can actually access the data and put it to work in a way that we've seen happen in retail and financial services and consumer products in some segments of the industrials sector, it is a very big unlock. And I think here's my prediction, we are within now a 5-year window of seeing that inflection point. And I'm excited about that.
And I think the good news there is we do have the ethical frameworks, and we have quite a few lessons learned from our experiences with the Facebooks and the YouTubes that we can hopefully go into this a little bit smarter, even if it's been a bit slower than we would like.
That's right, Joy. Thank you.
Anita, I turn it over to you. Thank you so much for hosting us, and thank you so much to Pamela from Innovative Medicines Canada. Really appreciate it.
Thank you all. Thank you so much.
Thanks to both. Tim, thanks for sitting down with us today to share your insights and experiences in combating COVID over the last year, and also attempting to make some predictions about what's to come in healthcare. We won't hold you to them. And Jodi, thank you for your expert moderation of today's discussion. Guests, we hope that you'll join us for some of our upcoming events. Next week, on Wednesday, March 17th, we'll host a discussion on the changing landscape of critical mineral supply chains, that's a mouthful, and the opportunities they afford Ontario as part of Canada's revitalization and growth efforts. And then on Tuesday, March 23rd, we're hosting an all-star CEO panel who will discuss powering a strong economic recovery post-COVID. We'll be joined by Daryl White from BMO, Mark Little from Suncor, Monique Leroux, as they examine what a healthy, resilient recovery looks like for Canada. Thank you to our AV supplier, Van Valkenburg Communications and livemeeting.ca for helping us come together virtually today. And thank you again to Innovative Medicines Canada for sponsoring today's event. Again, our events would not be possible without the generosity of our sponsors. Guests, thank you for joining us. Stay healthy and stay safe.
Thank you.
Thank you.